All right, so this time we're going to talk about antibiotic classes and antibiotic therapy. First, I want to show you this map. If you want to check it out, it's actually really nice. It's a resistancemap.cddep.org, and you can actually click on the specific pathogen and then the specific antibiotic. And as you can see, the varying degrees of color. The darker color means it's more resistant in that area. So if I click on, let's say, aminoglycosides like a gentamicin, you can see here in Asia, it's really, in Russia, it's really resistant in that area. It looks like they have a huge resistance problem with that. But then if we look up other countries, it'll tell you that. So anyways, I just wanted to show you that. I think it's really cool, and that's one way that we can find out if there's a lot of resistance going on. So I talked about in the other slides basically what antibiotics were, the types: bacteriostatic, bactericidal, that kill bacteria or that prevent the growth. So I'm not going to spend a lot of time on that, but just know signs of infection are fever, tiredness, not sleeping well, and inflammation. So if you have a wound, then you can get redness, swelling, heat, and pain. If you have a sinus infection, your sinuses inside probably look red and inflamed. And it just depends what type of infection. And the goal, remember, is to decrease the population of the bacteria to a point where your immune system can take over and deal with the invader and get rid of it. Selecting treatment, we talked about already. Culture and sensitivity is really important. When we can get a culture and sensitivity, we need to get that done, because then that will base our treatment off what the bacteria is and the sensitivity results, which will tell us which antibiotic is more efficacious for that specific bacteria. Bacteria classification, we have gram-positive, negative, as well as does it require oxygen or no oxygen. Now we know we have a resistance, which I talked about in the last slide set. So again, I'm not going to go into detail other than we have a problem and we need to really educate our patients. So that's something that you really need to study and know the education tips to talk to patients about with resistance. Let's talk about aminoglycosides first. Gentamicin, I highlighted the ones that are on your study guide. Gentamicin can be given intramuscularly, IV, and it also can be given as eye drops. So it's commonly given for conjunctivitis, bacterial conjunctivitis, or otherwise known as pink eye. For IV, though, it's usually only used to treat very serious infections caused by gram-negative aerobic bacilli. Bacilli is the exact name of the organism. It is a gram-negative and it requires oxygen. So just to know that those gentamicin really is just reserved for more serious infections. As you can see, that it's probably a narrow spectrum antibiotic. It's bactericidal. You do not have to know these indications. All you need to know is that it's reserved for more serious infections. I did go ahead and whatever's highlighted are things that are just real important. So the pharmacokinetics, you do not have to remember peak levels, absorption, but just know obviously that most drugs are metabolized in the liver. It's poorly absorbed from the GI tract, which is why there's not an oral indication for this medication. But IM injections work, and obviously IV. Depend on the kidney for excretion and are toxic. So that's why these are reserved for serious infections. And to tell you the truth, gentamicin is not given as much anymore. But since it is toxic to the kidney, this patient is most likely going to be inpatient, and we need to monitor the kidney function, which would be your BUN, blood urea nitrogen, creatinine, a byproduct of renal function, and urine output. Also, be aware that there's some contraindications. If you already have kidney disease or liver disease, you probably don't want to give it. Hearing loss. If someone already has hearing loss, you probably don't want to give it. If somebody has or is taking the medication and develops hearing loss issues, you want to say, we're done with this medication. I need to call your doctor. So, adverse effects, ototoxicity, hearing loss. So, it's affecting the hearing nerve. And nephrotoxicity, kidney damage. So, you're going to stop the drug if that happens. Again, whatever's highlighted are things that you need to pay close attention to. You don't have to memorize the other stuff. I'm going to skip over questions. All right, carbapenems. So, ertapenem is one. It is a newer class of antibiotics, and it can kill gram-positive and gram-negative. The ertapenem is the one, it's on your study guide. It does kill off the bacteria. It's bactericidal, and it is for, again, serious infections. I'm sorry. Okay. Pharmacokinetics. It is rapidly absorbed IM, and it can also be given IV. So again, this is something you see as inpatient and not as outpatient. One adverse effect. So this is what you're going to do with these antibiotics. There's always going to be like 1 to 2 adverse effects that you have to know about for teaching. Like, for example, the gentamicin was the ototoxicity, nephrotoxicity. Aminoglycosides are notorious for that. Now we're on the carbapenems. So those are notorious for causing Clostridium difficile diarrhea. And that can cause electrolyte disturbances, obviously dehydration. It's called pseudomembranous colitis, Clostridium difficile diarrhea. So with these patients, if they do have diarrhea, they want to report that. It's not just it might not be your run-of-the-mill common side effect. As we saw as I mentioned in the other slide set, there are common side effects. So a lot of antibiotics, we can tell them diarrhea can be normal, it's just going to go away. But there's going to be those specific ones that you know that your patient teaching is going to be a little bit different. Cephalosporins is cefaclor. Now, just to let you, as you can see, there's 5 generations of cephalosporins. What does that mean? Well, the first generation, these came out first. These came out second, then this came out, and that came out, and that came out. Some are resistant to some antibiotic or some bacteria, and some aren't. These are both bactericidal and bacteriostatic, and these are actually used orally. Some are given IM and IV. So let's see, like Zinacef you can give IV. Rocephin is commonly given IV and IM. Those are the most common. Cefadroxil and cephalexin are commonly given as an outpatient. They're really good for staph infections, good for gram-positive bacteria. So it's a broad spectrum antibiotic. It's well absorbed from the GI tract, which is why it's given orally. And there are some contraindications for placenta and breast milk. With pregnancy, we always have to look up any medication, and particularly, any medication, I should say, that we have to make sure is okay. One thing I want you to remember is cephalosporins and penicillins are sister, brother, cousins, whatever you want to call it. There's a cross-sensitivity. So if you're allergic to penicillins, there could be a higher likelihood of being allergic to cephalosporins, and vice versa. If you're allergic to a cephalosporin, there's a cross-sensitivity to penicillins. So please remember that. Also, there is a reaction called a disulfiram. I'm probably messing up that word. Reaction, it has to do with the ethanol so alcohol. With cephalosporin can have a reaction. It actually can be fatal. So make sure you study that in your textbook. And with these drugs, you can have a lot of GI side effects, like severe diarrhea. Now, again, many times it'll go away. It's not really known for causing C. difficile. I would tell patients, if you have a little diarrhea, it usually will go away. If it doesn't, then you need to call. I just remember giving my son this when he was a baby, and he had horrible diarrhea with it. But he finished it, and he got better. All right, now let's go to fluoroquinolones. Again, these are new, not new over the last maybe 15 years, I would say, or maybe even longer. I don't know, time flies. So it's one of the newer ones as compared to 1920s with penicillins that came out. So fluoroquinolones, they are also broad spectrum. Ciprofloxacin is the one that's most widely used. It's actually used for kidney infections. It's used for urinary tract infections as well as diarrhea, traveler's diarrhea. But that's the one that's on your list. The other one we commonly see is Levaquin or levofloxacin. Again, it's been kind of overprescribed, so there is some resistant issues. I did notice in the slide set that whoever made the slides did not spell correctly, so I changed it. It's urinary tract. It's tract, not track. So these are bactericidal antibiotics, and it will kill gram-negative, so not gram-positive. So if I feel like this patient could have a gram-positive infection, which we commonly see from the neck up, then I'm not going to go right to a fluoroquinolone with that. We don't go to that. So I always call it the big guns. So we do penicillins, cephalosporins, possibly a macrolide, which would be your azithromycin or erythromycin before you go to a fluoroquinolone. That is more reserved for, it should be more reserved, although in outpatient it's not always. There's some black box warnings. Now, black box warning means things that are side effects that came out. Most of the time it's post-marketing, and it's just a warning saying, attention, this could happen. And a black box warning is on these medications for tendon rupture and tendinitis. It was found that we see it more in athletes, elderly, but you can have a tendon rupture and tendinitis. So you have to be careful when prescribing these antibiotics. They are prescribed a lot, and tendon rupture and tendinitis, we see a lot more tendinitis than the rupture, but it is something that is a black box warning, and everybody should know about to talk to patients about that. Okay. Now let's talk about penicillins. These are the first antibiotics that came out in the 1920s, and there are some narrow spectrum and more broad spectrum penicillins. Penicillin G and V is very particular for strep pharyngitis, as well as some other types of infections. You don't have to know that. Your med list focuses on amoxicillin. I'm sure you've heard of that before, perhaps probably even taken it. Most of us have at some point in life. It's an old drug. It still works very well, and it's very inexpensive. But what ended up happening is so much amoxicillin was given out, and over time it became resistant. So the particular bacteria started breaking through the penicillin wall, basically, and stopped working. And so that's why we have something called a beta-lactam ring that now we have amoxicillin, and we have the clavulanic in the amoxicillin. It's called augmentin, and that breaks through that beta-lactam ring and can then kill the bacteria. How do we determine? Well, we determine it by culture sensitivities, also by research that's been done that we know that, for example, if it's a true sinus infection, first-line therapy is the augmentin. They found that amoxicillin might not work because of the resistance. They're bactericidal also. It is for severe infections caused by sensitive organisms, and it's absorbed GI tract. Again, you don't have to memorize these, just understand what penicillins are. It says severe infections. It is given for moderate to severe infections, but first line is usually amoxicillin if it's upper respiratory, and definitely not lower respiratory. It just depends what the organism is. Okay, so GI issues, of course, but we wouldn't stop the drug. So again, most of these antibiotics, if you even have nausea, diarrhea, we're not going to stop the drug. We're going to say, keep taking it until it's finished. Let's talk about sulfa drugs. Sulfa drugs, particularly Bactrim, the cotrimoxazole, that is the most common one. You'll see Bactrim DS commonly given out, and that is your Okay, so these are bacteriostatic, the sulfa drugs. There's a lot of drugs with sulfa in it. Your thiazide diuretics, which you're going to learn about that. Sulfasalazine for rheumatoid arthritis or joint aches and pains. It's indicated for pneumonia, MRSA, UTIs, pyelonephritis, so it is a broad spectrum antibiotic. Okay, I'm going to move on here. All right, so the one thing with sulfa drugs, there is a chance of Stevens-Johnson syndrome, so make sure you pay attention to that in your textbook. It causes widespread blistering, burns, dark red papules, fever. You are really sick. You can die from it. It has a mortality rate of about, I think, 25-ish%. So my sister-in-law ended up having Stevens-Johnson's from taking sulfasalazine, and she was very sick. You usually have to end up going to a burn unit, and it can actually burn the inside of your body too, and your organs. It can affect your heart function, kidney function, every organ in your body. So that's something that, that's when I tell people, if you get a rash or anything, please let us know. Now, Stevens-Johnson syndrome is really rare, but we always have to keep that in the back of our mind when we're doing our teaching. All right, tetracyclines. Tetracycline in particular is one of the more common ones that used to be prescribed. Now it's given more for skin issues like acne. We see doxycycline prescribed. I prescribe doxycycline for community-acquired pneumonia because we have a resistance rate or huge resistance with azithromycin. So I try to reserve that. And doxycycline is an older drug. It works very well. We also have resistance with doxycycline, but again, I have to take a good history and find out what the patient's taken in the past and what they haven't. But for your exam, it's focused on tetracycline. And no tetracyclines in general, these are the things that I want you to pay attention to, that it mostly has GI side effects, especially tetracycline, which is why it's not given as much anymore. There's better ones. Doxycycline can also cause that too. But photosensitivity, meaning you don't want to go out in the direct sun. You can get sunburned very easily, cause a rash, as well as longer term use, or even in kids it can stain teeth, and adults it can stain teeth. But again, that's why it's not given as much anymore. So please make note of that. Okay, now let's talk about tuberculosis. So Antimycobacterial's number one. There are 3 of them that are focused on for your exam. TB, tuberculosis, is very, very slow growing. It needs to be treated for a long time. Usually it is at least 6 months to a year, sometimes up to 2 years. It is the treatment regimen. So what does it do? It works a little bit differently. These act on the DNA of the bacteria, leading to lack of growth and then eventually death. But again, it takes a while for that to happen. During that time, we're going to monitor, because again, these are long-term antibiotics. We have we have to monitor if you have liver issues. we have to definitely either not, well, sometimes if they have TB, we have to give it. So you have to monitor the AST and ALT very closely. Those are the liver enzymes. If they've had hepatitis, cirrhosis, that's something you want to really monitor for. Effects, you can have central nervous system effects, neuropathy, so like tingling to the hands, feet. We usually give B vitamins, and it's usually a lack of B6 vitamin in particular. Those work with nerve, the B vitamins do. So that's why if you have a lack of that in your system, those are the symptoms you're going to get. Rifampin and INH can cause liver toxicity. And also rifampin, think rifampin red. It can cause discolored urine, saliva, tears, and sputum. Here's some other antibiotics. This is the last slide. These are things to pay attention to. The clindamycin, that's given for more severe infections. But remember, this one's notorious for causing Clostridium difficile, just like the sulfonamides. Not as much as clindamycin, though. That's just notorious for C. diff. The vancomycin and your telavancin is for severe infections again. So whether it's for C. diff or MRSA, that's an indication for it. Know that it can cause red man syndrome. So you get a flushed face, tachycardia, blood pressure goes up. So definitely read about that. Your macrolides are erythromycin. That can cause a lot of GI issues. And then also your the next class, which is your Zyvox, your linezolid. And that can cause C. diff also. How about that? It's used to treat MRSA, and it can cause colitis. This is more of a narrow spectrum antibiotic, and with these, it has an effect of an MAOI in the system, in your system. It's a specific enzyme pathway, and there are antidepressants out called MAOI inhibitors. They're not given very much anymore because they have so many reactions or interactions with foods and other drugs, but they're still out there and there's still people that take them. So anybody that takes an MAOI inhibitor, you don't want to give this medication to. All right, and that is it.